Well, welcome everyone. My name is Leonard Messner. I'm a professor of optometry at the Illinois College of Optometry, and this is the first of what we hope to be many podcasts that focus on the evolving research effort here at ICO. And I'm thrilled today to be sitting here with two of my esteemed colleagues, two real all-stars in the field of myopia management. And that is the topic of our discussion today, is the research efforts that are going on here at the college that are directed toward myopia and halting the progression of myopia. So I'm here with Dr. Yi Peng. Dr. Peng is the Associate Dean for Research at ICO, and her area of expertise is pediatrics and binocular vision. And along with Dr. Peng is Dr. Jen Harthan. Dr. Harthan is a professor of optometry. She's the chief of the Cornea and Contact Lens Center for Excellence and is a world-renowned authority in all things cornea external disease and contact lenses. So welcome both today. We're really thrilled to be doing this.
Thank you, Dr. Messner.
So I'd like to begin by talking a little bit about myopia in general, and from a contextual standpoint, beginning with you, Dr. Peng. And first of all, in your opinion, how is myopia affecting children today?
You know, years ago, people, not just the people, parents and even doctors feel like myopia, okay, that's glasses, okay, thicker glasses, that's high myopia. And particularly for eye doctor, feel like, okay, let's focus on the high myopia. For low myopia, there's not so much risk factors or complications going on, and it's just a prescription change. But that concept already changed. And nowadays in practice, we talk about it, every doctor matters, and also parents really concerned about myopia. And they feel like, oh, all the high risk and all the things we can do to slow down myopia change or progression, the better option for them is to act early. Start from today instead of wait and until the number go up.
So that's a very good point. And I know a question that pops up quite frequently is, what age, when do you begin thinking about treating individuals, treating children to stall the progression of myopia?
That's a very good question, Dr. Messner. And the average onset age was 8 years old based on the research data. But there's a trend, the onset age is moving younger, okay? And in clinic, I see 5, 6, 7. You know, very typically when the school start, and for US kids, the kindergarten, you know, they start at 5 years old. The vision demand is much higher by the time they go to school. So there's a trend, and not just in US, actually, in the whole entire world, the onset age is moving down younger than 8 years old. And occasionally, not every case, I do see even 2 or 3 years old, those preschooler, and starting, you know, already have myopia. And back to your question, the onset age is moving younger, and the peak time for myopia progression is between 7 to 14 years old. Yeah, that's a peak time.
But and just to add on to that, I think it's not even once they are a myope, right? So when they're at that younger age, even when they're a little bit hyperopic, right? So if they're 6 years old and they have a plus 0.75 or less than that, they're still considered high risk. The likelihood of them developing myopia is very, very high. So you want to start having those conversations early, because when they are showing that refractive error at that young age, they're going to become a myope. Yeah. So you want to talk in this in terms of more, we want to prevention, right? I think parents really understand what can we do to prevent disease, just like we talk about other disease states. So it's really kind of changing the way that we talk to individuals about this, and it's really changing our standard of care as well and how we manage this.
And you brought up a great point, Dr. Harthan, and that is, disease states. And, as we know, it's more than just a thick pair of glasses or wearing contact lenses or the nuisances of those types of things. But, this really is a disease and a blinding disease at least a small percentage of individuals related to retinal pathology, glaucoma.
Right. And it's not just about their refractive error. What we're really talking about is axial elongation.
Yeah.
So the longer the eye is, the higher they are, at risk for myopic maculopathy, retinal degeneration, glaucoma, cataract. So if we can keep that refractive error, but really that axial length below that 26 millimeters, even smaller than that, that's our goal. Is we want to keep them where they're at and prevent them from progressing in terms of not only refractive error, but really that axial length.
So 26 millimeters.
Yes, yes.
Sweet spot.
I mean, lower than that too, but yes, that's kind of that's where we start to see the visual,
But again, I see a lot of 20 pounds.
Yes.
Yeah.
It's already have
It's already
those
there,
change.
Yeah.
And plus, Dr. Messner, you're the retina specialist. I'm sure you saw those complications coming from myopia patients.
Well, I have a personal stake in this, and that's me. I am a high myope, and boy, if only the research that the two of you and your teams are performing would have been available to me when I was growing up, that would have been a great thing. But of course it wasn't. And getting back to that, when I was a child, and of course the main device that we had was television, and our parents would frequently take issue with standing too close to the television set, and then occasionally you get you're holding things too close whenever you're reading, and for a long time it was we thought, that's just a wives' tale, that kids hold things close because they can hold things close. They stand close to the TV because they can stand close to the TV. But now with all the devices that are being used, and as it relates to lifestyle, I was wondering if you could opine on that. There's lots of literature related to. I was in the airport not too terribly long ago, and there was as I was waiting to get on the plane, there was a young mother with twins, and they were stroller age. So, and both of them had their devices, their phones, and they were this them, like this. I'm like, wow, this is profound. It may be good for business, but this is not this is problematic. I was wondering if you could amplify it.
So in life, we see iPad, a cell phone right in front of the children's eye, and so it's a not a free but cheap babysitter that we are looking at. And not just that part in school, especially because of COVID, a lot of education moved to digital wise. Either in school education or at home homework. So think about it for our children. So the education part, they are right in front of there to do all the homework, right? Or do the education. At home, they have, depend on the family, and they have cell phone access or the iPad and a video game. So all those visual demand is right there in front of their eyes. And the research show during the pandemic, COVID-19, the prevalence of myopia increased. And there's some new research, very interesting, just coming from the AVO meeting last month. And they have the public health data not from US, from other part of the world showing after COVID, myopia prevalence going down. So the conclusion from those research is, because of the vision demand during COVID-19 and more close work and less outdoor activity, trigger the prevalence of myopia going up. And then after everything going back, the COVID-19 pandemic, children started to go out and play more and not so much, either online education or screen time, then prevalence going down. It'll be interesting.
Yeah, I think that's really true too for like the younger kids, right? So if they haven't developed it yet, to really stress to them to get outdoors and off the screens, especially for the younger kids.
Yeah, and I know that there are a lot of studies, particularly out of China, that have suggested that looking at the prevalence of myopia within cities, where a lot of time is spent indoors, as opposed to in the more rural areas where there's more time spent outdoors, that there are stark differences in the prevalence of myopia and also the rate of myopia progression. So we talked about some of the lifestyle and environmental risk factors that come into play as it relates to myopia, and of course, we're in this day and age of digital use, and try as we may, that's going to be a tough hill to climb. But I'd like to know from both of you, what about other genetic factors, other risk factors that come into play, or that you all think of as you're seeing this young child that is either less hyperopic than you would expect them to be, or showing signs of early myopia? What are some of the other risk factors that you take into consideration?
I think other risk factors that we look at are obviously Asian ethnicity, parental myopia. If both parents are higher myopes, the likelihood of that child going to become a myope is pretty high. Females tend to, unfortunately, for example, my daughter, I'm a myope, my husband's a myope. She is a myope. She's a baby myope. So, that's something that we knew that if we had kids, they were probably going to be myope. So we started monitoring her early on. But those are other things that you look at. You look at, especially, and I think that's an important conversation when you talk to parents. Parents who are myopes, they get it, especially if they are a higher myope, and you start having that conversation. Say, hey, like when, we were young, maybe these treatment options weren't available, but if you could have done something, would you have liked to? And I think that then brings them on board when we start treatment for their children.
That's a very, very good point. Another point, we try to emphasize in myopia clinic is we monitor the refractive error yearly. So we started the conversation early. We identify those high-risk patients early. Age is a big factor. Yeah. So for example, Dr. Messner, plus 50, let's give an example, plus 50 for 5 years old, I will be concerned, especially, if both parents are nearsight or myopia. And versus 15 years old, plus 50, I'm not concerned at all.
And the younger that they are, they're going to progress faster, and they're more likely to become a higher myope. So that's why you want to have that conversation early. You probably want to watch them closer. So rather than have them come back in a year, you might want to bring them back in 3-4 months, or at a minimum every 6 months, because if they, again, are 5 or 6 and they're plus a half, plus a quarter, they're going to end up a myope, but they're also going to progress faster than somebody who's 11, 12. So you want to watch them closer as well. So that's another part of the conversation. So instead of just bringing you back for your annual exam, we're going to see you back maybe in 4 months, in 6 months.
And you mentioned Asian ethnicity. I remember several years ago I was at a meeting in China, and I had the opportunity to be touring some of the eye centers throughout China, and I was shocked as it relates to vision rehabilitative services in China. The number one reason for individuals requiring low vision rehabilitation, it's not diabetic retinopathy, it's not age-related macular degeneration, it's pathologic myopia. And as both of you stated before, it's not just a matter of the nuisances of wearing glasses or contact lenses. It's really, particularly later in life, the pathology of posterior staphyloma formation, and along with that, of course, there's thinning of the choroid that we don't know exactly what that leads to, other than that it seems to play a strong link with respect to the the areas of geographic atrophy that many people with pathologic myopia develop later in life, and of course the myopic macular schisis, the fractures in Brooks membrane, the lacquer cracks that lead to subfoveal choroidal neovascularization, and of course the risk of retinal tears, retinal detachment, all of these things. So it's I think that the way you put it earlier is the way we should state this, and the way that we should look at this is that it's not just a visual nuisance, but it is a disease process. It is pathology, and the key time to intervene is you just as you just pointed out, is the sooner the better. Treat early, treat often.
Right.
And also the International Myopia Institution have a new concept.
Yep.
They talk about a pre-myopia.
Yep.
So the definition for pre-myopia is lower than 0.75. We are talking about a hyperopia and another risk factor.
Yeah.
So the concept right now is start early, education-wise, treatment-wise, early. The sooner the better.
Yeah, well, that's great information. So we've just reviewed some of the basic concepts related to risk factors of the development and progression of myopia, and I was hoping that maybe we could bring that home somewhat, and looking at the patient population that we serve here within the Illinois Eye Institute, and looking at that patient population, of course, as it relates to fueling many of our clinical trials. I was wondering if we could talk a little bit more about that as it relates to our patient population, and specifically looking at the research studies and the protocols that we'll get to later, but how our patient population impacts upon the protocols that are currently in place.
So we have very unique patient population at IEI, Illinois Eye Institute. About 80% of our patients are African American, and 10 to 15% Hispanic, and another 5% is Asian. And you can see majority of our patients are minority patients. And back to research. And actually diversity is a big topic for research. And for all the clinical trials we finish and we are doing, ICL play a huge role to enroll those minority patients.
And if I could tag on to that for just a moment, because I think you make a critical point in that so many clinical trials are done at institutions, and I don't mean this in a pejorative sense, but that the populations tend to be rather homogeneous. They tend to be largely Caucasian. They tend to be, should we say, of a higher income level. And as we know, looking at glaucoma studies and others, if you look at disease parameters, risk factors, so on and so forth, as it relates to particularly African American populations, it's different. And I think that's an excellent point as it relates to what are some of the current criticisms of clinical trials that are going on through NIH, NEI, et cetera, is that you've got to get away from these homogenous, largely Caucasian populations, and be looking at other races, other ethnic groups, to get more of a full picture of what's going on. So, that seems to clearly be one of the strengths of our research program.
Exactly,
if I may be so blunt, is looking at these more diverse patient populations. Do you agree with that?
Yeah, totally agree, Dr. Messner. And that's kind of another thing we can look at ICO research history. I joined ICO about 2005, and I remember at that time, and you know the history as well, Dr. Messner. I was told by the faculty at ICO, in order to do research here, it's better to do a retrospective charter review It's very
Yeah.
hard to have all patients come back
Yeah.
for a research visit. So, and that was 18 years ago. And now look at all the myopia clinical trial. Myopia is just one part of ICO research. It's not like everything. We do other study, as you might point out, a dry eye study, glaucoma study. But just to look at the myopia study, and 90% of the myopia study we are doing right now request at least 3 years or even 4 years. Is a 4-year study. So we have the patients in the study for 4 years. And I think about our patient population, 80% are African American patients. Yeah. And we all know for the research world, there are some bad memory, coming from
Sure.
African American
Sure.
patients. They support, us, and they supported the study, they participated in those study, and it's a big, change for ICO research.
Yeah.
You can see the environment, everything, changed so much.
So not only are you contributing to the body of work as it relates to underrepresented minority populations, which of course is very, very important, but correct me if I'm wrong, but your site is also one of the highest producing sites within many of these clinical trials.
Yeah. And for example, the NIH funded MTS1 study, and we are the top site because we get the most patients than any other site, number one enrollment site. And actually the paper is accepted by JAMA Ophthalmology, and it's not in press, it's not published yet, accepted. I'm not allowed to share the result.
Sure.
That's one of the myopia study.
But I guess that does dispel some of the rumors that myopia progression is something that you think of only in Asian populations and in Caucasian populations. It seems as though your data is suggesting that this is a disease that essentially affects all populations.
Absolutely.
And Dr. Harthan and myself, we have a study specifically look at ortho-K.
Yeah.
Is that effective to control myopia progression, particularly in African American population?
So Dr. Harthan, you mentioned earlier this concept of early intervention is critical, and to identify those individuals that are at risk for myopia progression and compelling myopia progression. So that being the case, what do you do when you see these children that are coming in that either have hyperopia that is not at the level that you would expect, or they're even beginning to show evidence of early myopia?
So I think taking a few steps back, right? So I am obviously not a pediatric optometrist, but I think it takes a lot of collaboration between those who do more pediatrics, if you don't consider yourself a pediatric optometrist, but at the same time, this is sort of also primary care optometry. We see patients of all ages. So, we wouldn't be doing our patients, the right service if we didn't take care of them. So what we did here at the college is it was a lot of communication and collaboration between our cornea and contact lens department and the pediatric department, and working together to take care of these patients. So we may not be the ones initially seeing those patients in our service, but the pediatric department might be, or in primary care they might be. So it took a lot of communication among all providers saying that
So as to increase their awareness.
It absolutely increased their awareness, but then also we were able to develop sort of alerts in our EHR system saying if you have this patient and they've progressed X amount within this year, send them to either pediatrics or send them to cornea and contact lens to have a myopia management consultation. And maybe then they are able to proceed with one of the treatment options. So even if you're not in a large facility like we are, there are ways to set your clinic up and monitor these patients closer. But I think it takes some work up front to set it up so that your staff, so that the providers are all on the same page, so that you're all having that same message when you're communicating to both the parents and the patients.
Yeah, great. So I know that there are a wide variety of treatment options now. You've got contact lenses, you've got spectacle lenses, you've got low-dose atropine. I know that we could probably discuss this for days, but can you give us a high-level approach as to what are some of the options that are available? You identify these kids that you believe are at risk, and what is it that you can do for them?
There are many options now, right? I think many years ago, it used to be thought that like undercorrecting a patient's vision or fitting them just with corneal gas permeable contact lenses that would slow their progression of myopia. Well, we know now that that doesn't work. Right now, there are several options that we have. We have low-dose atropine. We have myopia control spectacles. We have soft multifocal contact lenses. They are monthly lenses. We have one-day disposable lenses. There are dual focus soft multifocal lenses. We have ortho K lenses. We have combination therapy where we can combine soft contact lenses, multifocal contact lenses with low-dose atropine, ortho K with low-dose atropine. So I think there are lots of options, but when we select the option, we have to pick what's best for that patient. It may be that maybe they're not ready to handle application removal of contact lenses. Maybe the parent wants complete oversight. They want to be the one in control. So maybe we might select a contact lens over atropine. Maybe we have seen that the child is progressing faster than we like, so we might do combination therapy. So really we have to look at all of their risk factors. We have to look at where they're at. We have to look at their corneal topography. We have to look at their axial length. We have to look at a lot of different factors, their motivation, their lifestyle. Are they an athlete? What's their hygiene like? How are their morning routines? How are their evening routines? And then select an option based on that. And they all work. The literature has shown that all the options work in slowing. Nothing is going to stop the progression, but they all slow the progression anywhere from about 30 to 50%. And that, I think, is what we want to do is we're not going to stop it, but we can slow it. So that's what we want to do.
So it sounds like what you're saying is that it's much more than simply, well, if they're before the age of 5, we're going to do this or start with this versus an older age, we're going to probably start with this. And there may be, but that ties into the equation.
Yeah.
There are many, many other factors that contribute to both biological factors as well as other lifestyle factors that you're taking into consideration.
Lifestyle definitely a big factor. And another thing I want to add, it's kind of a loss of information for parents to digest and make the decision. They feel like, oh my gosh, will be easy if there's only one option because we have several options. Yeah. Could it be overwhelming for parents to decide? And typically I talk about, let's do the easy 2 factors, outdoor activity. I talk about outdoor activity right away. They're like, I can do that. Or I can make it, happen some days. And visual hygiene, make sure reduce the screen time, make sure the visual hygiene, and then talk about those options. And you have to, look at all the factors Dr. Harthan mentioned, and then decide, which one works better for this patient.
And there are going to be some who obviously have heard of this before, heard of the treatment options, and so they might come in saying, I have my child has some friends who are undergoing this treatment. I'm really interested in this. And they're going to have others, parents of children who have never heard of any of these treatment options before. But ultimately, they're coming to you for your expertise. So you have to be the one to make the best recommendation based on all their risks factors, based on their refractive error, based on what you see, their axial length, their age plays a role. So while you have the options and it seems overwhelming, you can maybe present them. But I also like to say, based on what I'm seeing, this is what I think is going to be best for you at this time. Not to say that we might have to change course along the way, because we do have to change course sometimes, just like any other treatment. When we're treating any other disease entity, we might have to change course along the way.
I know that, at ICO that you've been involved, our research teams have been involved in looking at a number of these very exotic spectacle options that we read a lot about. But to my knowledge, they're still not available in the United States. Is that true, or can you comment on that?
Correct. So there are three, up to today, there are three different type of special design spectacle glasses, and one is in the process to get FDA approved. And the other two, one actually, ICO is doing the clinical trial. We finished enrollment, and we are in the process to follow up patient for 3 years. The third one is coming to ICO. So I just had a conference call with the sponsor to talk about it, to do the clinical trial.
So it's still a matter of we're waiting to add spectacles potentially as
The treatment
a
option.
treatment option that you can include within your armamentarium.
So back to the spectacle glasses.
Yep.
All three are available in our neighbor Canada. Actually, I have patients ask me specifically why it's not available in US, and I bring those patients to ICU along, so for them to travel to Canada to get the spectacle glasses. And many of the parents, they're like, we can do vacation plus the glasses trip.
So it sounds like the early days of refractive surgery and LASIK, where we had this pipeline of sending patients across the border to Canada in order to have a procedure done that could not be done in the United States. So for those of our alumni and our friends that they're in Canada, we thank you for the work that you continue to do until we can do it here.
Thank you for the support and taking care of US patients.
I was wondering if you might be able to. I don't want to get too far afield or get too esoteric, but I was wondering if you could maybe explain a little bit about the optical principles. I mean, I hear this all the time. The peripheral focus, defocus, and so on and so forth. I was wondering if you could maybe is there a simple way of discussing and explaining that? And then on the flip side of that, how is it then that the optical corrections and the drug therapy are helpful? Not maybe, but are helpful in slowing the progression of myopia.
So I think the best way is maybe the exact mechanisms by which we slow axial elongation through these different treatments isn't fully understood, but I think most well-known and well-researched idea is the thought of myopic defocus. So the thought is that when peripheral light rays enter the eye and they're focused behind the retina, right, that's called hyperopic defocus. Right. So then what happens is the eye grows longer. So if we can, with our optical treatments, create peripheral blur that causes the light rays to be focused in front of the retina, that creates myopic defocus, and that therefore then slows down the axial elongation. So the whole goal is to create this peripheral blur, to create this myopic defocus, get those light rays in front of the retina. There's also, so in talking about orthokeratology, right, we have a flat base curve, we have this peripheral reverse curve. That peripheral reverse curve is what creates that peripheral blur. And same thing with the soft multifocals. We use the center distance, we get that peripheral blur, the dual focus. The thought is also with some of these contact lenses, we're creating more spherical aberration onto the cornea. Spherical aberration, we have light rays centering differently in the center versus the periphery. So the more spherical aberrations that we have as well, we're also getting more of that myopic defocus. Yeah. So it's with that peripheral blur, more spherical aberrations, changing the optic zone size, changing toricity of different lenses. There's a lot that we're actually doing right now in terms of research and looking at lens designs and how can we create more of this myopic defocus to slow the axial elongation.
From a very simple standpoint, with myopic defocus, you're more or less coaxing the eye to be growing inward as opposed to the eye chasing its stimulus in more of a retro fashion. Yeah, that's fascinating stuff.
Yep. it's actually really cool.
Yeah.
Yeah.
Okay, great. So we've been talking about the epidemiologic profile of myopia. We've been talking about risk factors and complications, and from there going into what are the multitude of treatment options that are available to slow progression. But as we all know, everything that is done in clinical practice ultimately links to these rigorous clinical trials that precede it. And I know that both of you research titans have been just extraordinarily involved in much of what is now commonplace throughout optometry and ophthalmology in the whole field of myopia progression. So I was wondering if we could talk a little bit about some of the research that has been done here at ICO, and also what is in the offing. What are some of the what are some of the innovative clinical trials that you're developing or that you're currently recruiting for? I think that's a great point because, of course, maybe our audience, that will be helpful as it relates to patient populations that we're looking to recruit for some ongoing trials that could lead to future breakthroughs.
That's a very good question, Dr. Messner. And when we talk about myopia research, and I can tell you, ICU has been involved in myopia research for a long time. And the first clinical trial, when we talk about a trial, the first clinical trial actually is on Ortho-K. And myself and Dr. Elise Chick-Lazier and Fromstein, we did a clinical trial on Ortho-K first. And then we look at the peripheral defocus. And then we move on to GNI. We have another clinical trial on Ortho-K. And then we finish one clinical trial, another one on low dose atropine. It's an NIH-funded study. Currently, we are doing 2 other clinical trials on low dose atropine. I still remember when we started the clinical trial 5 years ago in low dose atropine. And even some faculty asked me, we thought already done deal for low dose atropine. I said, no, it's not a done deal. We do not know the concentration. And up to today, we still try to figure out what's the best concentration. We all know 1%, no way, we cannot do it on a daily basis. Mm-hmm. There's some study to look at, okay, can we do it once a month for 1%, but definitely not on the daily basis. And then we try to figure out the sweet point, get a highest, relative good treatment outcome, but the side effect is lower. So we're still working on that. So there are 3 ongoing clinical trials for low dose atropine happening at ICO, and we finished the enrollment. It's not open to patients to join the study. We follow up, as I mentioned, 4-year follow-up for those clinical trials. And we have ongoing one to look at the special design glasses.
Could I go back to the atropine study?
Sure.
So if I interpret you correctly, so essentially you're still looking for the secret sauce,
Exactly.
and that may be patient dependent or other risk factor dependent, but this is essentially this is off-label treatment.
Still
of course, got it. And of course, we know, and I think it's important for our viewers to understand that as well, is that on a daily basis we implement off-label treatments for many things. So it's just that we don't have a definitive protocol as it relates to the desired concentration. It's still the research is still coming out, so it's more a matter of starting where you think you should and then augmenting accordingly.
And I can tell you, Dr. Messner, for the myopia clinic, the doctor at ICO, every one of us are very into research, and almost every doctor involved in those myopia clinical trials. So we know the ongoing research in myopia area very well. We kind of adjust our practice guideline based on the new coming research. Like the LAMP study just published about 0.05%, and that's different from the ATOP study. ATOP 1 and ATOP 2 suggest 0.01%. And the CHAMP study coming from US, they finished the clinical trial and suggest 0.01% works for myopia patients. So you can say even the research is still ongoing, and the conclusion could be different from this clinical trial versus the other one.
Yeah. I'm sorry, I didn't mean to. Because I believe you're just beginning to transition into optical treatments.
So back to all the clinical trials. So like the low dose atropine, finished one, still ongoing one, and we are studying 0.01%, 0.03%, 0.1% compared to the placebo. And then the spectacle glasses and the clinical trial we are doing right now already have some preliminary data from other part of the world, not from US. So that's an ongoing clinical trial. It happened right now at ICL. And we could have another one about another special design spectacle glasses, coming to ICL very soon. So you can say this is a very active, harder topic. And ICL is definitely doing a lot in this area. And luckily, we have very dedicated faculty who work super hard on the clinical trials. And we have the support from the college and from the Eye Institute for us to do the clinical trials.
We also have another orthokeratology study starting as well. So we're starting to enroll patients for those as well. So we have one starting looking at, there's research out there saying that a smaller treatment zone helps slow axial elongation, and then also looking at there's recommendations of when to move to a toric design versus spherical design. So we're looking at, do we change those recommendations and maybe do lower corneal astigmatism and look at lower elevation differences. So looking at those two things with a smaller treatment zone and changing in corneal astigmatism. So that's one of the ortho-K studies we have. And then also looking at empiric-based design versus software-based designs. Is there difference in efficacy in terms of, your 1 day, your 1 week, your 1 month outcomes on how you design your lenses?
So, we've been discussing these various options, some of them being optical, some of them being pharmacotherapy, and then of course, looking at combo therapy between the two. When do you cease therapy? You identify these individuals at a young age, and depending upon a variety of factors, you come up with a protocol that seems reasonable for that particular individual. And I know you've been saying that you follow them very, very carefully, not only looking at their refractive error, but also looking at their axial length measurements, right? So as you're following them along, how long do you do this?
I think that's a good question. I think we're learning as we go on. One of the projects that you guys actually did on graduate level students, we're seeing that they're still progressing. So we used to think that maybe the kids stop progressing between the ages of like 14 and 16, and you could stop therapy. Well, we're also seeing the rebound effect of stopping therapy, whether that's atropine, whether that's contact lenses, but then also with some of these newer studies, we're seeing that even graduate students are having a change in their refractive error and a change in their axial length. So do we continue on? So I think that I know I have changed my practice. So when I have somebody in one of these treatments, I will have them continue on until maybe their visual demands have changed, where they're not as, they don't have a significant visual demands, or, we talk about visual hygiene as well. But I think my practice has changed on some of the research that's come out.
Fascinating. Great. Well, I want to thank you both for taking the time to discuss this very exciting topic. As we said before, it's not just a matter of wearing thick glasses or contact lenses. It's a matter of disease progression and anything that can be done in order to prevent these changes from occurring within the eye. Again, thank you both so much, and thanks to all of you for taking the time to tune into this podcast.